Hi, my name is Dr. Hussein Hadi from the Department of Pathology and Forensic Medicine, Al Mustansariya University. This is a series of three lectures at which the lymphoreticular system will be addressed from pathological point of view. In today's second lecture, I will try to discuss the glandular fever in brief. In addition, malignant lymphoma will be highlighted in more details for its major subdivisions, namely Hodgkin's lymphoma, and hopefully the non-Hodgkin's type will be addressed in the last coming lecture. To start with, I will talk about the glandular fever. It is a general term for a disease characterized by fever, sore throat, lymphadenopathy, and atypical lymphocytes in the blood. It may be caused by primary infection with Epstein-Barr virus, cytomegalovirus, HIV, or toxoplasma. Epstein-Barr virus infection, otherwise known as infectious mononucleosis, is the most common cause. Infectious mononucleosis. This is caused by primary infection with Epstein-Barr virus. For the pathophysiology, the virus replicates first within epithelial cells in the pharynx, which causes pharyngitis or sore throat, and later replicates primarily within B cells. The host immune response involves cytotoxic CD8 positive T cells against infected B lymphocytes, resulting in enlarged atypical lymphocytes, called the Downey cells. In developing countries, subclinical infection in childhood is universal. In developed countries, primary infection may be delayed until adolescence or early adult life, mostly result in typical infectious mononucleosis. The virus is usually acquired from asymptomatic excretors via saliva, either by droplet infection or environmental contamination in childhood or by kissing. The laboratory diagnosis depends on the following findings. In increasing order of specificity, first, lymphocytosis with the characteristic atypical lymphocytes in the peripheral blood. Secondly is the presence of a positive heterophile reaction, which is also called a monospot test. The test relies on the agglutination of horse erythrocytes by heterophile antibodies in patient serum. Heterophile means it reacts with the proteins across species lines. Heterophile also can mean that it is an antibody that reacts with antigen other than the antigen that stimulated it. That means an antibody that cross-reacts. This test is specific but not particularly sensitive. The last one is a rising titer of antibodies specific for Epstein-Barr virus antigens. These are demonstrated by ELISA. The Epstein-Barr virus specific antibodies are: first, antibody against viral capsid antigens. These antibodies are initially of immunoglobulin M type and later of immunoglobulin G type. And secondly is the antibodies to Epstein-Barr virus nuclear antigen. This figure is for the microscopic appearance of infectious mononucleosis. Epstein-Barr virus infection transmitted by close human contact, often through saliva, most often in young adults, causes infectious mononucleosis with fever, sore throat, generalized lymphadenopathy, splenomegaly, as well as absolute lymphocytosis. Epstein-Barr virus infected B cells elicit a cell-mediated immune response with CD8 positive cytotoxic T cells that appear in the peripheral blood as atypical lymphocytes, which is also called the Downey cells, shown here with abundant pale blue cytoplasm, and they proliferate in lymphoid tissues. Initially, immunoglobulin M antibodies are formed. Both heterophile antibodies detected by a screening monospot test, as well as more specific antibodies against Epstein-Barr virus capsids antigens. The main treatment of infectious mononucleosis is symptomatic. It is worth to know that the administration of ampicillin or amoxicillin in this condition commonly causes an itchy macular rash and should be avoided. The next important subject in this lecture is called the malignant lymphoma, and it will be highlighted in more details. Lymphomas are a group of diseases caused by malignant lymphocytes, either T, B, or natural killer cells that accumulate in lymph nodes and cause the characteristic clinical features of lymphadenopathy. Although having different characteristics from their normal counterparts, the neoplastic cells of many lymphomas have the features of lymphoid cells at a particular stage of differentiation. It is said that lymphomas arise as a result of a series of mutations in a single lymphoid cell. The major subdivisions of lymphomas are first Hodgkin's lymphoma and secondly non-Hodgkin's lymphoma. This is based on the histological presence of red Sternberg cells in Hodgkin's lymphoma. We will discuss the characteristic features of such cells in the coming slides. This diagram illustrates the origin of lymphoid neoplasms. Here, stages of B and T cell differentiation from which specific lymphoid and tumors emerge are shown. Normal B cells migrate from the bone marrow and enter secondary lymphoid tissue. When they encounter the antigen, a germinal center is formed. Thus, in the bone marrow, the common lymphoid progenitor cells give rise to the pre-B lymphoblast, then the naive B cells. Once the latter cells enter to the lymph node, the mantle zone B cells, then the germinal center B cells are formed. The germinal center B cells could give rise to the marginal zone B cells and the plasma cells. The tumor emerged from the germinal center B cells are mainly the follicular lymphoma, Burkitt lymphoma, diffuse large B-cell lymphoma, as well as Hodgkin's lymphoma. Whereas the tumors that emerge from the marginal zone B cells are mainly marginal zone lymphoma, diffuse large B-cell lymphoma, as well as small lymphocytic lymphoma and chronic lymphocytic leukemia. The latter two could also emerge from the naive B cells. Multiple myeloma has mainly emerged from the plasma cells. For the T cell differentiation, it mainly starts from the thymus, at which the double negative CD4 CD8 negative pro T cells give rise to the double positive CD4 CD8 positive pre T cells, then the CD4 CD8 cells, and finally the peripheral T cells. The tumors that arise from the peripheral T cells is mainly the peripheral T cell lymphoma. It is worth to know that the precursor B or T lymphoblastic lymphoma and leukemias arises from the pre-B lymphoblast or the pre-T cells respectively. It is important to know that the biologic behavior and treatment of Hodgkin lymphoma differ from those of most non-Hodgkin lymphomas. Thus, making the distinction between the two is of practical importance. In addition, B and T cell tumors often are composed of cells that are arrested at or derived from a specific stage of normal lymphocyte differentiation. The diagnosis and classification of these tumors rely heavily on tests, either immunohistochemistry or flow cytometry, that detect lineage-specific antigens, for example B cells, T cells, and natural killer cells markers, as well as markers of maturity. By convention, Many such markers are identified by their cluster of differentiation CD number. Moreover, all lymphomas are derived from a single transformed cells and thus are by definition monoclonal. The major subdivisions of lymphoma are mainly Hodgkin's and non-Hodgkin's lymphoma. Herein, I'll try to discuss the Hodgkin's lymphoma in more details, and hopefully the non-Hodgkin's type will be addressed in the last coming lecture. Hodgkin lymphoma include distinctive group of neoplasms that arise almost invariably in a single lymph node, or a chain of lymph nodes and spread characteristically in a stepwise fashion to the anatomically contiguous nodes. In fact, Hodgkin lymphoma accounts for 30% of all lymphomas. In addition, the molecular studies have shown that it is a tumor of B cell origin. It is important to note that Hodgkin's lymphoma is characterized morphologically by the presence of distinctive neoplastic giant cells called red Sternberg cells, as well as large mononuclear cells called Hodgkin's cells, in a reactive background composed of lymphocytes, histiocytes, and granulocytes. Moreover, the neoplastic red Sternberg cells typically make up a minor fraction, about 1 to 5% of the total tumor cell mass, making Hodgkin lymphoma more difficult to study than typical non-Hodgkin lymphomas. Hodgkin lymphomas are now understood to be unusual tumor of B cell origin. The neoplastic red Sternberg cells are derived from germinal center or post-germinal center B cells in the vast majority of cases. To some extent, the Epstein-Barr virus genome is present in the red Sternberg cells in up to 70% of cases of the mixed cellularity type, and a smaller fraction of the nodular sclerosing type. Thus, Epstein-Barr virus infection is likely to be a contributing step to the development of Hodgkin lymphoma, particularly the mixed cellularity type. It is said that the disease can present at any age, but is rare in children and has a peak incidence in young adults. There is an almost 2 to 1 male predominance. The usual clinical presentation is with painless asymmetrical lymphadenopathy, most commonly in the neck. Typically, the disease is localized initially to a single peripheral lymph node region, and its subsequent progression is by contiguity within the lymphatic system. The constitutional symptoms, such as fever, weight loss, and sweating, are predominant in patients with widespread disease. In addition, alcohol-induced pain in the areas where disease is present occurs in some patients. For the diagnosis and histological classification, it is made by histological examination of an excised lymph node. The histologic diagnosis of Hodgkin lymphoma rests on the definitive identification of red Sternberg cells or their variants in the appropriate background of reactive cells. There are certain morphological features for the red Sternberg cell, which is observed as a large cell with an enlarged multilobulated nucleus, having prominent nucleoli and abundant, usually slightly eosinophilic cytoplasm. In addition, red Sternberg cell is considered as a very large cell, about 15 to 45 micrometer in diameter. Particular characteristic feature is that these cells have two mirror image nuclei or nuclear loops, each containing a large inclusion-like acidophilic nucleolus surrounded by a distinctive clear zone. Together, they give an owl-eye appearance. Moreover, the nuclear membrane is distinct. It is important to note that the typical red Sternberg cells have a characteristic immunophenotype as they express CD15 and CD30. Such classic red Sternberg cells are common in the mixed cellularity subtype, uncommon in the nodular sclerosing subtype, and even rare in the lymphocyte predominance subtype. The blood tests may show anemia, neutropenia, eosinophilia, and raised ESR or LDH. This is a diagrammatic representation of the different cells seen histologically in Hodgkin's lymphoma. Note the red Sternberg cell, which is binucleated with large inclusion-like nucleoli and abundant cytoplasm, surrounded by lymphocytes, plasma cell, macrophages, and eosinophil cells. This figure is for the Hodgkin lymphoma. The high-power view of a lymph node biopsy showing typical multinucleate red Sternberg cells with a characteristic owl eye appearance, surrounded by lymphocytes, histiocytes, and an eosinophil. You could notice the red Sternberg cells with the two large mirror image nuclei having prominent eosinophilic inclusion-like nucleoli, surrounded by a distinctive clear zone with thick nuclear membrane, giving an owl eye appearance. The cytoplasm is abundant and unusually slightly eosinophilic. Regarding the classification of Hodgkin's lymphoma, 5 subtypes of Hodgkin lymphoma are recognized. These are: first, nodular sclerosis; secondary, mixed cellularity; third is the lymphocyte predominance, as well as lymphocyte-rich and lymphocyte depletion. The last two subtypes are uncommon. For the WHO classification of Hodgkin lymphoma, they are divided into nodular lymphocyte predominant Hodgkin lymphoma and classical Hodgkin lymphoma. The latter are subclassified into 4 pathologic subtypes based upon red Sternberg cell morphology and the composition of the reactive cell infiltrate seen in the lymph node biopsy specimen. These are nodular sclerosis classical Hodgkin lymphoma, mixed cellularity classical Hodgkin lymphoma, lymphocyte-rich classical Hodgkin lymphoma, as well as the lymphocyte-depleted classical Hodgkin lymphoma. The last two subtypes are rare. At the end of this lecture, we will discuss the Hodgkin lymphoma subdivisions in brief. So, we will start with the nodular sclerosis Hodgkin lymphoma. It is considered as the most common form, with equal frequency in men and women. Most of the patients are young adults and has a striking tendency to involve the lower cervical, supraclavicular, and mediastinal lymph nodes. The overall prognosis is excellent for such subtype. For the morphology, the nodular sclerosis subtype has a variant of the red Sternberg cell called the lacunar cell. This cell is large and has a single multilobate nucleus with multiple small nucleoli and an abundant pale staining cytoplasm. The appearance of the cells lying in empty spaces or lacunae are observed in formalin fixed tissue processing, as the cytoplasm often retracts. It is worth to know that the immunophenotype of lacunar variants is identical to that of other red Sternberg cells found in classical subtypes, thus mean they express CD15 and CD30. Along with the lacunar cells, there are varying proportions of lymphocytes, eosinophils, and histocytes. Other morphological features we should be familiar with is that the classical red Sternberg cells are infrequent, and there are collagen bands that divide the lymphoid tissue into circumscribed nodules. This is a classical Hodgkin lymphoma of nodular sclerosis subtype. The low-power view shows well-defined bands of pink cellular collagen that have subdivided the tumor cells into nodules. Note the bands of pink collagenous tissue dividing the fields. These are microscopic pictures of a classical Hodgkin lymphoma of nodular sclerosis subtype. You could notice in the left image the lacunar cells as indicated by black arrows. At high power, there are scattered large cells with a surrounding prominent clear space, an artifact of formalin fixation. These are the lacunar cells characteristic for the nodular sclerosis type of Hodgkin lymphoma. The second subtype is called mixed cellularity Hodgkin lymphoma. It is the most common form of Hodgkin lymphoma in patients older than 50 years of age and comprises about 25% of cases overall, with male predominance. In such subtype, classical red Sternberg cells are plentiful, within a distinctive mixed cellular infiltrate of small lymphocytes, eosinophils, plasma cells, as well as benign histiocytes. Compared with the other subtypes, more patients with mixed cellularity have disseminated disease and systemic manifestations. This is Hodgkin lymphoma of mixed cellularity type. A mixed cell population is present in these microscopic images. Note the large cells with large pale nuclei containing large purple nucleoli. These are red Sternberg cells that are indicative of Hodgkin's disease. Most of the cellular content of foci of Hodgkin lymphoma consists of reactive lymphoid cells. The many different cell types include small lymphocytes, eosinophils, and macrophages. The other subtype of Hodgkin lymphoma is the lymphocyte-depleted classical Hodgkin lymphoma. It is accounted for less than 1% of cases, characterized by the presence of large numbers of red Sternberg cells that are often bizarre morphologically. In addition, it is associated with older age and HIV positive status. Patients usually present with advanced stage disease. The fourth pathologic subtype is the lymphocyte-rich classical Hodgkin lymphoma. It is rare and accounts for about 5% of cases. In such subtype, red Sternberg cells of the classic or lacunar type are observed, with a background infiltrate of lymphocytes. Clinically, the presentation and survival patterns are similar to mixed cellularity Hodgkin lymphoma. The final subtype is nodular lymphocyte predominant Hodgkin lymphoma. This subgroup, comprising about 5% of Hodgkin lymphoma, affected lymph node in a nodular appearance. It is characterized by a large number of small resting lymphocytes admixed with a variable number of benign histiocytes. In addition, eosinophils, neutrophils, and plasma cells are scanty or absent, and classic red Sternberg cells are extremely difficult to find. The nodular lymphocyte predominant Hodgkin lymphoma is characterized by the presence of lymphohistiocytic L and H variant red Sternberg cells that have a delicate multilobe buffy nucleus resembling popped corn called the popcorn cell. L and H variants usually are found within large nodules containing mainly small B cells admixed with variable numbers of macrophages. Other reactive cells, such as eosinophils, are scanty or absent, and typical red Sternberg cells are rare. Unlike classic red Sternberg cells, L and H cells are positive for B cell antigens, mainly CD19 and CD20, and are negative for CD15 and CD30. It presents mostly as isolated cervical or axillary lymphadenopathy and have excellent prognosis. This microscopic picture is for the nodular lymphocyte predominant Hodgkin lymphoma. The high power view showing numerous mature-looking lymphocytes. In addition, you could notice the lymphocytic and or histocytic L and H type of cell called the popcorn cell that is characteristic of this condition, as indicated by the arrow. These microscopic images show the immunoperoxidase stain with antibody to CD15, a marker for red Sternberg cells and variants for Hodgkin lymphoma mixed cellularity type and Hodgkin lymphoma lymphocyte predominant type. Note the paucity of red Sternberg cells with the CD15 immunohistochemical stain at the right. Regardless of subtype, the diagnosis rests on the definitive identification of red Sternberg cells or variants in the appropriate background of reactive cells. Immunophenotyping plays an important role in distinguishing Hodgkin lymphoma from reactive conditions and other forms of lymphoma. In all subtypes, involvement of the spleen, liver, bone marrow, and other organs may appear in due course and takes the form of irregular nodules composed of a mixture of red Sternberg cells and reactive cells, similar to what is observed in lymph nodes. Here is a suggested reading. Hopefully you will find it useful for you. This is the end of the lecture. Thanks for your attention.